Okay, so we're just going to look at the knee. So we're going to look at the passive assessment of the knee. So obviously you would have already done your active assessment and made your notes on that. So as you remember, the passive assessment of the knee, we're going to take contact underneath the knee, so in the popliteal space. We're going to bring the leg up controlled, holding onto the calcaneum, okay, and bring the leg up to about 90 degrees from the hip, and then you're going to take a contact over the eyes of the knees, okay, so basically where the meniscus will be, and also you're just going to find the lateral and the medial joint line, okay, and you're going to look at the knee and you're going to try and see how much flexion you can get through there. So you're looking ideally for about 120 degrees, give or take, of flexion of the knee, okay. And while you're doing this, you're assessing the quality of the movement, okay, the end feel, and obviously you're paying attention to if your patient has any pain at all. You're then going to move on to extension and hyperextension. So extension of the knee, we should get about 5 to 10 degrees. So we're going to pin down the femur above the patella, so right above the patella through here. Okay, I'm just going to apply a little bit of extension force through the calcaneum again, so we'll bring the leg up through there. Okay, about 5 to 10 degrees is normal. Obviously you would have already checked the movements of the patella, because you should have done that first. That was my deliberate mistake. Okay, so obviously check for movements of the patella, so patella, so medial, lateral movements, superior, inferior movements. So you're just making sure that that moves quite nicely and fluidly through that. Okay, so obviously showing you on this one just superior movements through here. Okay, lateral movements of the patella, medial movements of the patella, and inferior movements of the patella. Then we're going to move on to internal and external rotation of the knee. So internal and external rotation, again taking control of the popliteal fossa, and we're going to bring it up, okay, and we're going to take it to 90 degree at the hip again, about 90 degree at the knee joint as well. Okay, dorsiflex the foot, proper full dorsiflexion of the foot through here, and you're going to apply your external rotation through here. Okay, so you should have about 40 degrees of external rotation of the knee, and then internal rotation, again about 30 degrees of internal rotation. So 30 degrees of internal rotation and about 40 degrees of external rotation through the knee. So the only additional movements that we're going to look at from the knee that we wouldn't have looked at through the passive assessment, active assessment, is medial and lateral gapping, or valgus and valgus stress. Okay, so we'd take the knee and just put about a 5 degree flexion into the knee. You're going to contact just below the tibial joint line on the lateral aspect, okay, and just with your holding the ankle against your body with your elbow, okay, you're just going to gently twist and create a gentle medial gapping motion through there, okay, and then you're going to do the same but going laterally, so opposite positions of the hands, and the same movement but going laterally through there. That's really more of an accessory movement of the knee, but we're just ascertaining how much movement there is through there. We'll then go on to look at ligamentous stress tests. Okay, so we'd start with, or we will start with the anterior drawers line. So knee probably about 45 degrees from the hip, so 45 degrees from the hip, 45 degrees from the knee. Take a seat onto the foot, and both your hands behind the tibial joint line. Okay, and then what we're going to do is we're going to try and draw the tibia forwards. Okay, and as we're doing that, we're obviously looking for pain and talking to our patient about it if it's uncomfortable, if it hurts, and we're also assessing how much movement we get. We're also looking for a nice sort of end feel, so a strong tissue end feel. We don't want there to be too much movement or excessive movement, so that would indicate there may be a problem with the anterior cruciate ligament. We can also look at Lachman's. Okay, so about 5 to 10 degrees of flexion in the knee. Okay, so I tend to put my leg underneath the knee, fix over the top of the femur. With my other hand, I want to sort of try and grab hold of the tibia. okay, and then what we're going to do is we're basically going to bring the tibia forwards and backwards, okay, so like this, and then what we're looking for is a knocking, okay, so a nice solid knocking as you come to that end point, which is where the ACL is kicking in and stopping the additional movement through there. Okay, good. We can then look at PCL, so again up to about 45 degrees, maybe slightly higher, okay, and you're going to take contact on the tibia again, and this time we're going to push the tibia posteriorly, so we're testing the patency of the posterior collateral ligament as we drive the tibia posteriorly on the femur. Again, looking for pain, looking for excessive movement, and what the end feel is like. We can also look at something that's called the posterior sag sign. Okay, so when we take the foot up, or the knee up to 90 degrees, hip up to 90 degrees, what we're looking for is, or what we don't want to see, is an increased space basically between the tibial tuberosity and the inferior pole of the patella. Okay, so there could be a little dip through there, but with the posterior sag sign, as you bring the leg up, the femur, which is the tibia, will drop. Okay, so you'll end up with an increased divot basically between the tibial tuberosity and the inferior pole of the patella. We can then look at patellar fusion. So I would do it on the leg nearest me, but I don't want the leg over here. So what we're looking at here is if there's any inflammation underneath or within the joint capsule itself, so underneath the patella. So what we're doing is we're going to take what we call milking the knee. Okay, so we're going to bring all the fluids towards the knee. We do this 2 or 3 times. Okay, and then we take our hand over the top, keeping our position with our hands over here. We bring a finger over the top of the patella. Okay, and we tap down, so we push down. So it's a strong, continuous push. Okay, if this is the patella, I'm not tapping the patella, I'm pushing down on the patella. The tap is if the patella has a layer of fluid underneath it, which would mean there is joint effusion or inflammation within the joint, then you'll hear a tap because it's basically lifted it up off of the femoral condyles. So as you push the patella down, you get a tapping type noise that runs through there. Okay, that would be a positive test. Okay, we could also look at Clark's test, okay, or patella grind, which is uncomfortable in most people. And what you're going to do here is you're going to basically, with the webbing of your hand, again I'll do it on the knee opposite, I would do it on the knee nearest me, with the webbing of your hand you're going to take a contact over the top of the superior poles of the tibia and basically hold that through there. What you're going to do is you're instruct your patient to contract their quads, and as they do that, you're going to allow the movement, okay, but you're going to resist the movement. So you're not going to hold it firm here and get them to contract their quads, because all you're going to do then is drive that patella down into the femoral joint, which is going to be painful regardless, okay? Whereas if there is some maltracking or if there is some inflammation, if we get them to contract their quads, and we allow it to move back and then relax again, okay? But we apply overpressure to it. So we're trying to encourage, or we're trying to push it against the femoral condyles, okay? But we're not just trying to jam it right into them, okay? And if there is degradation of the cartilage, if there is inflammation on the inferior side or of the patella, then that would cause pain. We can also push the patella medially, okay? So you would have to have the leg in a neutral position to do this, right? So you would not lift it up, okay? I'm just lifting it up so you can see. And then if you push the patella medially, you can get your fingers underneath the inferior surface of the patella, so the retro patellar cartilage under here. And then you can have a feel around the retropatellar cartilage. And that can be painful in conditions like osteochondritis or condylomation patella, or just arthritis of the patella. Okay, so then we could look at the McMurray's test, so for the meniscus. So again, we bring the leg up. Okay, now with McMurray's, what we're going to do is we're going to be gapping the medial joints, okay, and compressing the lateral joint. Okay, and then we'll do it the other way, and we'll be compressing the medial joint and gapping the lateral joint. But to start with, we're going to gap the medial, compress the lateral. So I'm going to take my two fingers. I tend to wrap these around the hamstring tendons through here. Okay, we're going to dorsiflex the foot. We're going to externally rotate the foot through here. I'm going to keep that knee compressed against my chest through here. Okay, and then I'm going to basically pin it into me, and I'm trying to increase the valgal strain through here. So I'm trying to open up that space. And as I'm doing that, I want to keep that hip in line. So I don't want to be dragging it over here. And then I'm going to take it down. Okay, so I can increase the stress that I put through that. So again, dorsiflexion for the foot, external rotation through the foot, pin that tendon down, pin that joint right down next to you, and take it down here. A positive test would be pain. Hey, spider, would be pain on the joint line. It's okay, and it's okay. It's alright. Gone good with
Daddy?
Yes, darling.
Are we allowed anything to eat yet? Not puddings, but are we allowed anything else to eat?
Not yet. Give me 5 minutes, okay? Maybe 10.
And then we'll start dinner. Okay?
5.
5
Okay.
minutes and we'll come start dinner.
Okay. So then doing the same for the lateral joint. You can probably edit that bit up, maybe. Doing the same for the lateral joint. Okay, what we're going to do is this time I'm going to increase the gap laterally. So I'm going to dorsiflex the foot, internally rotate the knee. Okay, and then put my pressure over the top of the femur here. Okay, and basically increase the valgus stress through there, through the knee. So we're going to bring it in through here, internal rotation, pressure over the knee, bring the leg in, so into adduction, and then again I'm going to take it down through there. Okay. When we do these tests, when we are opening up part of it, we're testing the outer aspect of the meniscus. When we're compressing it, we're testing the inner aspect of the meniscus, okay, because the outer part of the meniscus is set up for tensile forces, the inner part is for compression forces. So if we were gapping the medial and we were getting pain laterally, that tells us that it's the inner part of the meniscus that's potentially damaged. And if we were to get it medially while we were gapping the medial, it tells us that the lateral part of the meniscus is potentially damaged, or that the MCL may be damaged or something along the outside that resists tensional forces. Okay. We could also look at medial and lateral gapping, okay, but actually trying to test the medial collateral ligaments and the lateral collateral ligaments. Okay, so again, bringing it up, pinning the foot against your side through here, breaking the knee ever so slightly, making sure the femur's straight, okay, as in we're not allowing sort of rotation through here. Pin it into the side of your body, contact below the joint line, okay, on the fibular side, and basically apply valgal stress through there. Okay, that's obviously going to stress and open up this aspect of the joint, which if you've got any MCL damage, medial collateral ligament damage, or even some outer fibers of the meniscus damage, that may cause pain. Okay, you could do the same to the other side. We can do exactly the same, standing in the same position through here, okay, but we really have to concentrate on keeping that knee fixed and working through there, or we can step inside the leg, again making sure we keep that knee straight or the femur straight through there, pinning the leg to the other side of our body, and basically then just applying the valgal stress through that knee joint through here. Obviously that would stress the lateral collateral, the lateral aspect of the meniscus. Okay, and that's